Hi, everybody. My name is Dr. Ilana Gurevich, and I am a naturopathic physician and licensed acupuncturist with a board certification in naturopathic gastroenterology. Today, I'm going to present a really fun and exciting case for you about microscopic colitis and chronic vaginitis. This is one of the cases that I love. This is one of the reasons why I love using the GI map stool test so much, and I use it exclusively in my practice because it really helps me understand a lot of the underlying cause of my chronic GI patients. My practice is almost exclusively gastrointestinally based. And so this was a very great referral to me. This is a stock photo of a woman in her 60s. Tracy is my patient. Tracy is a woman in her 60s who came in with a history of microscopic colitis that was diagnosed with colonoscopy and endoscopy. Tracy's past medical history is that in her 40s, she started developing significant diarrhea and weight loss. It went on for multiple years. She saw her primary care. She saw a lot of different providers until she finally got into the gastro office. The gastro office did a colonoscopy and an endoscopy. They did the right thing and they decided to take biopsies. And those biopsies came up positive for microscopic colitis. So by the time she came in to see me, she probably had a 10-year history of having microscopic colitis. She used a lot of antibiotics on and off over that time because a lot of those diarrhea episodes she or her doctor assumed were some kind of foodborne illness. So they would put her on antibiotics, and she is pretty convinced that the antibiotics were what increased the worsening of her microscopic colitis. The other thing that she suffers with is bacterial vaginosis, and that also has been exceptionally more difficult to control. It's of more recent onset. She's only been dealing with it for about 2 years. But again, some oral antibiotics at first, and then now she manages it with metronidazole gel and clindamycin vaginally to avoid antibiotic use. The other thing to know about her microscopic colitis history is that she has a history of trying to control the microscopic colitis from a lot of different mechanisms, and nothing really worked. And so what she discovered, not by the way from her gastroenterologist, but from some other random, I think maybe she met a doctor at a dinner party who told her about mesalamine. Mesalamine is a non-steroidal anti-inflammatory medication. And on the mesalamine, she has definitely better, maybe even good management of the microscopic colitis. She doesn't have chronic diarrhea that's urgent every day, but she does have intermittent diarrhea still. And so it's controlled, but it's not great. As far as medication history, this is the list of Tracy's current medications. She's a postmenopausal female, so she utilizes an estradiol patch and oral progesterone. She takes the mesalamine to manage the microscopic colitis. She takes a vitamin D3 daily. She takes a children's multivitamin, really because the adult multivitamin, she didn't tolerate it. It would cause a bunch of symptoms, and she wanted to have some kind of control. She takes a high dose probiotic. She's not sure if it helps, but she still takes it. And then she'll occasionally take non-steroidal anti-inflammatory drugs for her leg pain, but she understands the risk of that, so she uses it pretty sporadically. As far as the children's I was pretty clear that it's most likely closer to candy than to multivitamin, but she liked it and she didn't want to stop using it. Tracy's diet is pretty impeccable. She, because of her symptoms, her diet is pretty restrictive, but it is very clean. It's organic. She avoids sugars. She focuses on high fiber foods, proteins, and limited dairy. When she has dairy, it's a lactose-free half and half, which she utilizes in her coffee. And then she consumes a pretty good variety of fruits and proteins throughout the day. She actively engages in exercise, weight-bearing exercise, 3 times a week. She reports some moderate alcohol intake, but not excessive. And she does not use any recreational drugs. She is sexually active. The sexual activity has been a problem recently, mainly because of the chronic vaginosis. And so she's trying to figure out how to manage that, but she does have pain and discomfort after intercourse, especially when the BV is flares. So she's trying to manage that, but that is definitely one of the goals of her treatment. So what I'd like to do now is I'd like to take a look at the GI map report to kind of chunk out what I'm seeing in the context of Tracy's history and Tracy's case. Whenever we start, the first page of your GI map report is the pathogens page. I lovingly refer to this as the bad news page. Anything on this bad news page, I generally choose to treat with pharmaceuticals. The bad news page generally, but not always, has things that are a little bit more acute, and sometimes they have a lot more urgency. On this page, we find bacterial markers that are very significant, like C. diff, enterhemorrhagic E. coli, Salmonella, Shigella, Campylobacter. We also find frank parasitic findings like Cryptosporidium, Entamoeba histolytica, and Giardia. And finally, we find acute viral infections. Luckily for Tracy, nothing came up on her bad news page. And so I said, good job. We don't have to treat anything here. Let's move on to the more chronic stuff. The next thing that I look at is I look at the H. pylori. H. pylori is definitely significantly more controversial than it was in the past. There is no clear yes or no or if you should treat. The history of H. pylori is we've actually found H. pylori detected in our, very distant ancestors from Africa during the Stone Age. They found H. pylori present within their GI. However, in the late 80s, physician Robin Warren out of Australia infected himself with H. pylori, and that caused him gastritis and an ulcer. At that point, the pendulum ended up swinging away from thinking that H. pylori was a natural part of the microbiome to thinking that it was exclusively a pathogen. And now what we're seeing is that H. pylori is swinging the other way. Now we know there's a lot more nuance in the H. pylori conversation. When I'm looking at this particular test, which gives us virulence factors that are very, very actually useful, the first thing that I'll be looking at is CAGA or VACA because those are generally tied to virulence. Diagnostic Solutions Lab actually has a really useful GI map interpretive guide, so it might be worth checking that out just to get more of a breakdown on how you look at H. pylori, when to treat and when not to treat. As far as treatment goes for H. pylori, we have options of either pharmaceutical treatment, which is either triple or quad therapy now. Quad therapy involves PPIs, 2 antibiotics, and a bismuth, or you can have herbal treatments. If the patient is not symptomatic, but they still want to treat H. pylori, then I'll often use the herbal option. With the triple or quadruple pharmaceutical options, you do have to be concerned about the repercussions of using those strong pharmaceuticals affecting the microbiome. Luckily, in this situation, there were no virulence factors present and she was not symptomatic. The next thing we're going to look at is her commensal or keystone bacteria. If you look at her report, you see that she had 3 markers that were flagged on this portion of the report. She had elevated Enterobacter species, lower Akkermansia, and then low Firmicutes or low Firmicutes in the phyla class. Let's chunk these out one at a time. Let's break down Acromania muciniphilia first, because that was definitely what was going wrong, or one of the things that were affecting Tracy. So, whenever I think about Acromansia, it is one of the most important parts of the microbiome to make mucin within the large intestine. Mucin is basically the thing that protects your intestine, the layer that protects your intestine from the microbiome. When talking about what's happening in a GI tract, I always think of it with an analogy of a house. So there is the dirt, that's the microbiome. Then there's the foundation of the house. That's the mucin layer. And then there's flooring, which is where you are. Now, just like in a house, you don't want the foundation to be broken and you don't want the dirt to be touching the flooring. The reason for that is if it does, it brings in mold, it brings in weather, it brings in insects. It definitely, the barrier function is no longer there. That is also true while looking at the microbiome. Akkermansia it's not the only microbe that's responsible for making that mucin layer, but it is a big part of what it does. And if the intestinal microbiome are touching the cells, then you end up with inflammation or irritation of the GI lining. That absolutely makes sense for somebody like Tracy, since she is dealing with microscopic colitis. The next thing that was elevated for her was her Enterobacter species. Enterobacter species are associated with contributions of metabolic functions that take place within the GI. A close cousin of the Enterobacter species is the enterohemorrhagic E. coli. The Enterobacter species as a whole is significantly less understood than E. coli, but what we tend to know is it contributes to biodiversity within the microbiome. If it is in low abundance, then that shows that there is more diversity within the GI, and that actually has association with better health. If it's overgrown, then we see a lot less diversity within the GI, and that actually leads to more poor outcomes. The next thing that we're going to look at is her bacteroides and her Firmicutes. Now, just a reminder, everything we were talking about before this, we were looking at species. Now we're looking at phyla. The phyla, what we know at the moment is there are about 50 different bacterial phyla that reside within the human colon, but the two most predominant ones are Bacteroides and Firmicutes. Bacteroides is an anaerobic bioresistant non-spore forming negative rod, and Firmicutes is a gram-positive aerobic species made up mainly of Bacillus and Clostridia, and they produce endospores to survive. What we're looking at here is we're looking at how healthy the forest is. You know, the species, that's the trees. The phyla, that's how healthy the forest is as a whole. The fact that she has low Firmicutes is a sign that she doesn't have as protective of a microbiome as she needs. This, of course, is not a big surprise, considering that we know how affected she was by her intractable microscopic colitis and how it was impossible to get control of. So the fact that she has lower Firmicutes really does make sense. Let's jump into her opportunistic bacteria. She had two opportunistic bacteria come up. This actually looked a little better than I expected. She had Enterococcus faecalis come up and Streptococcus species. Enterococcus faecalis is a species that is known to be protective if it's in balance, and if it gets out of balance, it's known to cause a bad neighborhood to become even worse. So in balance, it's one of the key maintainers of the gut homeostasis. It contributes to maintaining homeostasis of different GI species that belong there, and it keeps them generally in check. The other thing that it does is it plays an immunomodulatory role by activating CD4 and CD8 T cells and B cells to contribute to the development and regulation of the immune system. In healthy individuals, Enterococcus faecalis exists as a commensal bacterium forming part of a normal gut flora. However, if the Enterococcus faecalis gets overgrown, then it can lead to a worsening environment. So it does a couple of things. One, it is a biofilm formation bug. It has the ability to form biofilms, which enhance the survival and resistance to antibiotics and human host immune responses. So it builds walls around itself and its friends to protect them from the elements of the GI tract. Also, it is a pretty big player in horizontal gene transfer, so it can acquire pathogenic properties from horizontal transfer of pathogens, so it can teach itself and other bugs about drug resistance And it can basically switch DNA to become more drug resistant. Finally, it can cause inflammatory changes. We see Enterococcus faecalis often present in inflammatory bowel disease like Crohn's and UC, and it perpetuates gut inflammation, especially in susceptible individuals. So it's always a question in this whole, whenever we're looking at microbiome, we always wonder, do the species make the environment worse, and that's why they have their changes, their organic changes, or do the organic changes predispose to the microbial changes? And I am a little bit more inclined to assume that because you have a microbial shift, then you end up with more changes, and that leads to inflammation. Time will tell if my theory bears water, but that's kind of what I'm believing right now. The other thing that we see is Enterococcus faecalis increase when there's lots of antibiotic use. So we see it following antibiotics. We see an upregulation of the Enterococcus faecalis, which isn't necessarily there before we give them antibiotics. Let's talk about strep next. Strep is another one of these opportunistic species that can be good and can be bad. The Streptococcus species do play beneficial roles, especially when we're looking at carbohydrate metabolism. They're able to utilize carbohydrates from food intake as nutrients, and they help the metabolic system break down and utilize the carb nutrients. Also, they do engage in symbiotic relationships or interactions with the microbiome to help maintain stability and health of the microbial community if they don't get overgrown. However, if they do get overgrown and they have an opportunity to take over, then strep can cause lots of issues. One of the things that we see is strep species can get systemic infections or can lead to systemic infections like endocarditis, meningitis, and bacteremia. We see this with strep pneumonia and strep pyogenes, which are well-known pathogens responsible for significant diseases like pneumonia, strep throat, and even invasive infections like necrotizing fasciitis. Sorry. The other thing is we do see a higher amount of strep overgrowth associated with chronic diseases. So we see people having more strep findings with coronary artery diseases, pancreatic cancers, and systemic inflammation. And that is what she is dealing with. She's dealing with a very, very chronic microbiome disease. When looking at her opportunistic overgrowth bacteria, especially focusing on the commensal overgrowth microbes, what we see is a presence of Methanobraceae, but absolutely no Desulfovibrio species. This is not ideal because we know that Desulfovibrio has some antioxidant properties, and low levels could be a consequence of history of her, plentiful antibiotic use. If these guys are elevated, they have more of an association with constipation, which very clearly is not this patient's underlying cause. Looking at her opportunistic inflammatory and autoimmune related bacteria, the only one that's coming up present in not flagged amounts, but present, is the Citrobacter species. Citrobacter is very clearly a makeup of the normal microbiome if it's kept under control. If it gets overgrown, then we do see it coming up higher in patients with irritable bowel syndrome and with general dysbiotic changes within the GI microbiome. It has a tendency to be a little bit more antibiotic resistant, and so it can share the genetic information of antibiotic resistance. And it does have the potential to overgrow in environments where we've given antibiotics and they've wiped out the microbiome. When looking at the commensal inflammatory and autoimmune related bacteria, we are seeing this elevation in Enterobacter species. We did talk about this earlier when we were on page 2 looking at those results. Enterobacter species they should make up about 1% of the microbiome, and they're commonly found in healthy individuals without any issue. if there is an elevation of that Enterobacter species, this can play a role into turning a pretty mild bacteria into an opportunistic species, and it could prove to be quite disruptive. We have seen data that shows that in inflammatory changes within the intestine, as seen in something like inflammatory bowel disease or microscopic colitis, there is an overabundance of Enterobacter species. And that's exactly what we're seeing with Tracy. This could be one of her underlying causes of what's causing issues with her microscopic colitis. On a positive note, she did not have any Candida or fungal species coming up within within her GI map. She didn't have any viruses coming up in her GI map at all. And she didn't have any parasites coming up on her GI map. Those are all things that I have found in other microscopic colitis patients, but it's not anything that I found in her GI map. Let's take a look at her intestinal health. And I kind of want to break this section up piece by piece. So first, let's look at her steatocrit and elastase. These are both very, very useful markers. Steatocrit is a marker that looks at fecal fat that comes out within the stool. It's a marker that actually has been very well validated for looking at excess fat within the stool or fat malabsorption. And I'm not clear why it's not used more because it really is a very reliable marker. Generally, I like to see a steatocrit non-detectable or below DL. She's coming up with a 9, which means she's got fat malabsorption in her stool. When we pair the steatocrit to the elastase, that's really important because elastase is also a very well validated marker that looks at pancreatic insufficiency. So basically, she is not secreting enough enzymes, and because those enzymes are not being secreted, she's not breaking down her fats, her carbs, or her proteins enough, but this is looking at fats in particular, and that's why the steatocrit is high. So those two you do need to look at in relation to one another. If the elastase is high, if the elastase is normal or high, and the steatocrit is also high, that tells you that it's most likely a bile acid malabsorption problem and not a fecal fat problem. So these, I don't love the fact that her steatocrit is high and her elastase is low. GI markers look well within normal limits, no occult blood, and no beta-glucuronidase coming up. Her immune markers, her secretory IgA is actually within normal limits, but her anti-gliadin IgA is elevated. And then her eosinophilic activation protein is within normal limits. So I questioned her about that anti-gliadin IgA, and what she discussed was that she has very, very sporadic exposure to gluten, but she does occasionally drink beer, and she's pretty sure that's where it comes from. Her calprotectin is 0, so no white blood cell infiltrate within the stool, and her zonulin, which on the entire test, everything that we talked about were large bowel markers, except for the zonulin. That's a small bowel marker that tells us about active intestinal permeability, and that looked really good. So let's quickly talk about treatment for this patient. The first thing that I did was I had a lot of concern about that elevated steatocrit and that lower elastase. And so I talked to her about starting proteolytic enzymes. There were pharmaceutical and supplement options. And so we started the one that was more comfortable for her. Also, that very low Akkermansia, I was sure, was causing a reaction or causing an issue with her microscopic colitis. So we did introduce an Acromania-based probiotic. We also had a very long discussion about fermented foods. And frankly, I am much more inclined to utilize fermented foods over utilizing probiotics for my general population. I feel like the data is there. I feel like history supports the use of fermented food. And so for me, it always makes more sense to do it with diet. I think of probiotics, oral probiotics, similar to air conditioning. They're really helpful when you use them. But once the air conditioning goes off, then we're not really getting any help anymore. That's not true with fermented food. And in fact, there hasn't been a culture outside of modern Westerners, in really Americans, in the last 100 years that did not utilize fermented food as their main source of preserving food. And so, in the 1940s, we both developed antibiotics and refrigeration, and then proceeded to wage a crazy war on bacteria in all varieties. And since then, our microbiome has really been completely deteriorating, and we see significantly more GI intestinal based health. And then I talked to her about discontinuing gluten, mainly because that number was elevated, and that could explain some of the times when she was having that transient diarrhea. In summary, I don't know if I could have helped her as much as I did without the GI map. Tracy came in as a 60-year-old female with a 20-plus-year history of microscopic colitis and unmanaged diarrhea. She had tried everything and nobody could really stabilize her. It was really the GI map's ability for me to hone in on what exactly was going on with her overall health that let me come to a solution. And that is really why we were able to develop some stability in how she was feeling overall. I have a bunch of references for you guys if you want to look at where I got a lot of my information from, especially about the different microbiome species. Hopefully, this information was helpful to kind of get a thought process about how to look at a GI map and how to look at the species in particular to figure out what to treat and what not to treat. Okay, have a great day.